We've been studying the molecular biology, the virology of coronaviruses in animals and in humans, SARS and MERS, CoV-2. And so now I would like to focus a bit on the disease, on COVID-19. Now, I'm just a scientist. And so I've asked a colleague and a friend of mine, Galya, who is the president of infectious disease of the Sheba Medical Center, the largest medical center in Israel, and has been on the front lines from the very, very beginning to help us and talk about COVID-19 as a disease. Galya, it's great having you here.
Hi.
We've all experienced flu, common cold, and we've been told by some people that COVID-19 is just another type of flu.
Yeah.
What would you respond to that?
I don't agree at all. You know, it's really quite different diseases. And I think that there are several points. First of all, you know, that with corona, we have a lot of asymptomatic carriers. You know, it took us a time really to realize that about a third of the patients are asymptomatics, and that about 60% really catch the disease from asymptomatic carriers.
I see.
And in influenza, we don't have it. You know, it's very interesting that we don't know in influenza, that we know for so many years, how many people are really asymptomatic. Not a lot, that's for sure. Now, another difference between the two diseases is the seasonality. You know, influenza, you have it only in the season. You have it in the winter, and you know, in summer, you don't have influenza. In corona, you have it all the time. So the seasonality really quite different. Now, you know, also although, you know, in influenza, you have a lot of antigenic drift, antigenic shift. In corona, you have the variant, but, you know, I see now we have 2 years and see how many different variants and different response to vaccines, etc. So it's also different. Now, the numbers are totally different. You know, in corona, we know nowadays, 2 years, more than 6.3 million died. In influenza, in a year, estimation, you know, respiratory diseases, not all of them were influenza, about 650,000 cases. So you can't, you know, compare them. So it's really different, quite different diseases.
So in reality, COVID-19 is different from flu, especially in various aspects, like it transmits asymptomatically. That's really important. And we also see that it's prone to variation. But on the other hand, both diseases, flu and COVID-19, are respiratory diseases. So I would expect that there are some similarities in the clinical presentation. On the other hand, you mentioned the fact that they are distinct and unique in COVID-19. Can you contrast the two diseases, flu and COVID-19?
Yeah. So COVID-19 is very similar to influenza.
Okay.
You know, fever, cough, shortness of breath, myalgia, you know, muscle pain, sometimes arthralgia, very similar. However, there's some unique manifestation that we don't have in influenza, and this is the loss of smell and taste. Then, about 12 days later, there is activation. The virus activates, you know, all the inflammation system, all the cytokines, and cause, you know, what we call cytokine storm. And also the coagulation system, it causes a lot of thrombi. And here we see a lot of, you know, what we call multi-organ disease. We see, you know, cardiac failure, myocarditis. We see CNS disease like encephalitis, Guillain-Barré. We see kidney failure. We see really multi-organ failure. And coagulation, we see, you know, thrombi and much more microthrombi all over the body. You know, in autopsies, we've seen a lot of thrombi, macrothrombi in the lungs, in the kidney, all over the body.
So in addition to a respiratory disease proper, we're seeing a lot of other manifestations in other organs and so on.
Yeah.
And what about temporally? What about long COVID?
I must say that, we have to separate long COVID to two quite different diseases. One I call residual disease. And residual disease, for example, patients who were in the intensive care with, COVID pneumonia, and mainly patients who were ventilated, and they have a lot of damage to the lungs. And they have fibrosis of the lungs, and sometimes they need respiratory rehab, and sometimes also they need lung transplant. So that's something else. If you had really COVID pneumonia, severe COVID pneumonia, you probably will have some residual lung disease. Now, in about 10 to 50% of patients, they have, different symptoms and signs that we can't, attribute them to specific pathogenicity, and we called it long COVID. And here we see patients mainly with fatigue, extreme fatigue, shortness of breath, that we can't find, with all the tests. If we're doing X-rays, CT scan, lung function test, exercise test, we don't find anything. Phenomenon like tachycardia, that is not explainable. Dysphagia, I had several patients after corona, severe pain or severe difficulty in swallowing. We see a lot of cognitive problem, brain fog. Many patients really complain that they are not able to concentrate, to memorize. And also a lot of pain, muscle pain, and we don't find anything.
So COVID-19 and flu are very different. Let's now compare COVID-19 with previous coronaviruses, SARS and MERS. How do they differ?
Yeah, it's very, very interesting because, SARS in 2000, 2003, there were about 8,000, 9,000 cases. And the mortality rate was about 10%.
Exactly.
In MERS, only 2,500 cases with mortality rate of about 36%. And I think that the main reason is that, in SARS and MERS, there are no asymptomatic carriers. Mm-hmm. And asymptomatic carriers cause really a lot of transmissibility. SARS and MERS, when you're sick, you're contagious. If you are not sick, you're not infective. So all the infection control measures were much more effective in MERS and SARS. You're doing isolation, no transmission.
Now, undoubtedly, the most effective preventive measure has been the COVID-19 vaccine. It's been a total game changer. On the other hand, there have been various concerns about adverse effects. Can you tell us a little bit about myocarditis and how worried we should be?
Okay, so first of all, because, so many millions of people got vaccines already, so for sure you'll see a lot of things that are not related to the vaccine. So it's very, challenging to know if a side effect is really related to the vaccine itself, or, you have it because so many people were vaccinated. So myocarditis, yes, it is a side effect of the vaccine. Because we really did a lot of work with the Ministry of Health, and we found that, yes, we have more myocarditis following the vaccines than we have without the vaccines. However, we see it mainly in young men.
Why?
Nobody knows why. But you see it quite more in males, in young, not children, but young men. And
15 to 20.
Yeah, exactly. And you see it mainly following the second vaccine, not so following the first vaccine. And almost all of them are very mild.
You were one of the first to actually treat COVID-19 patients in Israel, a new disease. Was there any source for information, advice from the world that helped you in treating our Israeli patients?
Oh, I like this question. No, I'm thinking back 2 years ago. It was really so challenging. And, I can't forget, because we treat the first patients in Israel. And, everybody looked at me, how to treat the patients. And I have no idea how to treat a disease, a new disease. And, my best friend was the tweeter, really. And I made archive. These are really very, until the corona, I was not in the Twitter.
Cool. And over the time and the experience gained, has there been any major shift in the way you approach COVID-19 patients and treat them?
In the beginning, we treat only hospitalized patients. And, we have, antiviral drugs. We had then anti-inflammatory drugs and anticoagulation drugs. And I think that the most important thing was really to kill the virus. Because if we'll kill the virus, we'll prevent also the cascade of the inflammation, the coagulation. And now the main change or the main difference that happened now is, shifting the treatment from hospitalized to outpatients.
To outpatients.
Really.
Mm-hmm.
And outpatients, we have 3 platforms. We have what we call pre-exposure prophylaxis.
Okay.
We have post-exposure prophylaxis and treatment. And the pre-exposure prophylaxis is what I mean, healthy people who are at risk and preventing getting the disease. So one thing is for sure all the vaccines, and that's everybody gets. And then what we call monoclonal antibody, the EvoShield, that nowadays we are giving it to high-risk patients, mainly immune-compromised patients who are at risk for severe disease. And they're not exposed, they're healthy, they didn't have corona, and we are giving them the monoclonal antibodies of AstraZeneca to every 6 months to prevent of becoming infected.
And these antibodies are directed against?
They're directed against the spike proteins, but against several, different
epitopes.
Epitopes, exactly.
I see.
And so we have the pre-exposure. Now we have the post-exposure. The post-exposure prophylaxis, if somebody, for example, have, a husband, a wife, or kids that are infected, and he's at risk, and he's not infected yet, so to give him also monoclonal antibodies. The monoclonal antibodies that we can't give now for post-exposure prophylaxis are not effective against the Omicron. Mm-hmm. They were effective for the Delta, for the Alpha, the Regeneron and the Bama of Eli Lilly, so they are not effective anymore. So, and treatment, early treatment. And early treatment, that's very important nowadays. We're administering treatment for patients with mild to moderate corona who are at home, outpatients, and they're at risk of developing...
So what is the basis of the treatment?
And there are 2 relatively new medicines. One is what we call Paxlovid, and Paxlovid is a protease inhibitor. And it's, a very good study in the New England found that it's prevent hospitalization and death in 90% of patients, which is very good.
Which is great.
Yeah. However, the problems with the Paxlovid, a lot of drug-drug interactions, a lot. So really, we have to sit with each patient to see if there are any drug-drug interactions.
So you shouldn't just randomly take Paxlovid?
No way.
Yeah.
And the other one is molnupiravir, which is a polymerase inhibitor.
Okay.
And molnupiravir, the study shows that it's effective in 30%. It's not 90%, but it's okay, 30%. And there is no drug-drug interaction.
Okay.
And we don't have yet, Pfizer and MSD should have studied together to see, like in HIV, that you have to take, combination therapy, the cocktail. Yeah. So I think they should do it.
As we sum up, the horizon is obviously great, but how close is the horizon? When are we going to be relieved from corona?
Oh, I don't have a crystal ball, so I really don't know. I have no idea.
Are we progressing or are we before a more severe wave?
First of all, we have the vaccines. I think that vaccines did great, really, are very effective, even in this Omicron wave. Although the vaccine was not so effective against infection, however, against severe disease and mortality, it was showed already, it was very effective. So the vaccine are effective, however, they're effective for 6 months. Who knows? And now everybody say, okay, about third or half the world was infected with Omicron, so maybe we have immunity. But now we know that neutralizing antibody and even the T cells are not so effective against the Omicron, even though you were sick.
Yeah.
So we don't know if we will have another variant and what will happen. So I really don't know. We have good weapon. It's the vaccines. It's the new drugs. However, the virus, I think, is more clever and more rapid than the human being.
Still on the warpath.
Yeah.
So Galya, I want to thank you very, very much. It's really been important and interesting for us to get a perspective from somebody who is in the front line, treating patients and dealing with the families. Thank you so very much.
Thank you.